but we should be recording now. A few housekeeping things before we get started. My name is Suzanne Jones. I'm the Safe Schools Coordinator with the Division of Elementary and Secondary Education, and I'm hosting this training today. We've also got with us Sharia McDonald, our state school health nurse, and Lisa Monday, our coordinated school health specialist in the health unit. I appreciate them being here. They are the outreach piece to the curriculum, to the teachers, and to the nurses in the school. And then we have with us our presenters from the Department of Health, and I'll let them introduce themselves in just a moment. So I know a lot of you have registered for this session. If you registered through ESC Works and got the link directly that way, or from me, from my message, then that means I have you on my list and we'll make sure you get a certificate. If the link was forwarded to you by somebody else, or if you're not sure if you're registered and you would like a certificate, I'm going to put my email in the chat and just send me a message and make sure that I have a connection to get your certificate back to you. Also, I know sometimes our teachers will kind of gather up, especially if you're on the campus together. There may be 2 or 3 of you in a room watching this under one name, and that's completely fine. If the person who is logged in on the screen, if your name is on the screen, if you will just take a moment and send me an email to that same address and just let me know who is in your room. I need their name and their email address, and we'll make sure you get a certificate as well. We are recording this session, and it will be posted on the Safe Schools Trainings webpage. I'll put that link in the chat as well. And if you would like to be on my mailing list to know about some of these upcoming trainings or resources that we're putting out for Safe Schools, you can sign up. I'll put that link in the chat as well. The last one that I'm going to put in is a link to a Google form for an evaluation. It's just 6 questions, giving us feedback on the presentation today. I know our presenters always like that kind of feedback. Then also, if you have any suggestions of sessions that you would like to see or resources that we can put out or look for you for, at the schools. So if you've been in Zoom meetings before, you may be familiar with some of the workings, but I want to go over that. You should see at the bottom of the screen a live transcript or a CC button. It should be kind of right of your screen in the bottom. You can turn that on and you can monitor the closed captioning pieces. So you can hide them, you can make them bigger. You've got several different options there if that's helpful for you. Also, we've learned with all our Zoom experience that sometimes if the presenter's video lags, the audio will still keep up, and that live transcript will help you keep going along and following along. So if we have those connectivity issues, you might consider turning that on just to be able to keep up with the wording at the bottom. You're also going to see kind of more to the other side of the screen, a chat button, and that's how you can interact with us today. If you have questions that you'd like to pose to our presenter, please feel free to put them in there. I'll be monitoring that and bring those questions to her at an appropriate time. So feel free to use that. And also, if our presenter asks a question or says something that you want to chime in on or just give a hooray, feel free to do that as well. It's always makes it a little bit more interactive if we can have some feedback from the audience instead of just the Brady Bunch pictures going on with us. So thank you again for joining us today. And without further ado, I'm going to turn it over to Z.
All right. Thank you so much for that, Suzanne. I am super excited to be here. Thank you guys for allowing us to be in your virtual space and be a part of your meeting. My name is Zawaka Nabilo. I am the HIV Prevention Program Manager here at the Arkansas Department of Health. As Suzanne mentioned, everyone calls me Z. Also with me is 2 of my colleagues, Darian Adams. She is the public health educator for the prevention team here at the Arkansas Department of Health. And then there's also Crystal Brown. She is the testing and training coordinator here for the HIV prevention team for the Arkansas Department of Health. And so we are super excited to be a part of this. And as Suzanne mentioned, if you guys have any questions, don't hesitate to ask. I ask a lot of questions as well. And so feel free to ask or put them in the chat. So getting right to it, the topic is addressing HIV in youth. What can I do as an educator? And so for those of you who may not know, Arkansas is actually one of the states selected for federal funding for ending the HIV epidemic. And so in order to do that, youth have to be a part of the conversation. In order to effectively in the HIV epidemic that cannot be for only certain groups and certain populations. Youth are an important part of that particular piece. And then you as educators are also critical to what that looks like as it relates to HIV prevention as well. And so before we get into that, I do want to talk about, well, let's talk about HIV first and foremost. What should everyone know as it relates to HIV and AIDS? We don't want to assume that everyone is knowledgeable about certain topics. And so let's talk about what should we all know. And so first and foremost is that anyone can get HIV. There tends to be a misconception that unless you belong to a certain group or unless you identify a certain way, getting tested for HIV or being affected by HIV does not pertain to you. Now, regardless of age, race, gender, or sexual orientation, anyone who engages in condom-less sex can benefit from getting tested for HIV. CDC actually recommends that anyone between the ages of 13 to 64 get tested for HIV at least once as part of routine healthcare. And so again, that does include our young people. Now, let's talk about HIV. What does it stand for? So HIV stands for Human Immunodeficiency Virus. HIV is the virus that causes AIDS. AIDS stands for Acquired Immunodeficiency Syndrome, and technically it's classified as the last stage of an HIV infection. Does everyone who have HIV transition into AIDS? No. HIV does affect the person's immune system. It actually attacks those cells, those CD4 cells that help someone's body fight off disease and infection. Once those cells become 200 or less, that person is diagnosed as having an AIDS diagnosis. Now, that has to be done by a medical professional. So can you go and get an AIDS test? No. You can get tested for HIV, but AIDS is a clinical diagnosis. HIV is the test that someone can go and get done prior to being diagnosed with AIDS. Now, Suzanne did mention that this can be an interactive session, which I love because we do that during our training sessions. So when we're talking about HIV, we know what it stands for, we know what AIDS is and what that stands for, but how is HIV transmitted? What fluids, to be more specific, is the virus transmitted through? Anyone? And if not, it's okay. So we can talk about it. So HIV, the virus, is actually transmitted through blood, semen, vaginal secretions, and breast milk. So someone who is living with HIV has to transmit these fluids from their body to someone who is not living with HIV in order for them to become HIV positive. HIV is not transmitted through urine. It is not transmitted through saliva. That is a myth. In order for someone to get HIV through saliva, they have to drink gallons of someone's saliva who is living with HIV. And the last time I checked, no one is interested in being on a saliva diet, okay? So that is a myth. HIV cannot be transmitted through urine or saliva. It is only transmitted through blood, semen, vaginal secretions, and breast milk. So let's talk about those activities that can actually, and do we have a question, Suzanne?
Yeah, the question was, what about rectal fluids?
So there are some studies that are showing that it could potentially be transmitted through rectal fluids. Typically, it's also because blood is sometimes present in the rectal fluids, thus transmitting the virus. So there are some studies that are showing, yes, it can be, but it's also because that there's blood present typically in those fluids. Was there any other questions? I love it. Okay. So let's talk about activities. So when we're talking about fluids, what activities can potentially transmit those fluids in order for someone to potentially become exposed to HIV? So as you can see here, unprotected sex typically is the most common. So we say unprotected or condom-less sex. Also, drug addicts. Typically, HIV transmission occurs with drug addicts through needle sharing. Also, we've been finding here recently that it's not just drug addicts who are also needle sharing. Someone who is diabetic and having to use needles in order to maintain their condition in terms of insulin also may be needle sharing with friends or family in the event they don't have what it is they need to get their medication. And so oftentimes, sometimes we do see needle sharing and thus potential HIV transmission. So it's not just drug addicts who are needle sharing. Sometimes it can be those who have chronic conditions as well. Blood transfusions typically don't happen anymore. Now, when someone is donating blood, the blood is tested for HIV, and so that is no longer a potential exposure as it relates to HIV because the blood is tested for HIV. Then there's also pregnancy. A mother who is living with HIV can have an HIV negative baby, but it is possible for her to also transmit HIV to her child, whether it be through breast milk, as we talked about that being one of the fluids. And once the baby is born and their immune system is developing, typically the baby is started on medication to ensure that as their immune system is building, that they don't transition into having HIV as well because they're still transitioning from having their mother's system to developing their own. And then there's also those non-sterile instruments, whether it be in a clinical or non-clinical settings such as tattoo parlors and things of that nature. If those instruments aren't sterile and there is blood present in those instruments and the person whose blood is present is living with HIV, then yes, that is a method of transmission. And then also those occupational sticks as well, that's also a potential route of transmission, even though it is rare. HIV is not transmitted through touching, kissing, sharing utensils, insect bites. No, you cannot get HIV from a mosquito. That is a myth. Again, HIV stands for human immunodeficiency virus. You cannot get it from bugs. It is summertime. Sharing pools, touching, all of those things, those are not routes of transmission. All of that is safe to do. Another thing, too, that's important when we're talking about HIV is talking about signs and symptoms. So as you can see, the word may is highlighted because not everyone who is living with HIV shows these signs and symptoms. Also, these signs and symptoms are not exclusive for HIV. Anyone who may have infection or disease can develop swollen lymph nodes, but it is a symptom for HIV. There's also recurrent fever, night sweats, weight loss for no apparent reason, constant tiredness, diarrhea, decreased appetite, white spots or blemishes in the mouth, flaky or rashy skin, oral and vaginal yeast infection, and then short-term memory loss. Again, I want to highlight that these signs and symptoms are not exclusive for HIV. Occasionally, I have short-term memory loss. If I'm working too hard, I am constantly tired. The only way to know for certain whether or not you are living with HIV is to go and get tested. It's also important to talk about the medication that's available when we're talking about someone who has an HIV positive diagnosis. So as you can see on the slide to the left, in the 90s, once upon a time when HIV first hit the scene, someone who was living with HIV had to take up to potentially 20 pills a day just to maintain their HIV diagnosis. Now, that is no longer the case. Someone can take as little as 1 pill a day to maintain their HIV positive status. An HIV positive status is actually considered a chronic disease now because, like high blood pressure, like diabetes, with medication, it can be maintained. Treatment is also prevention. Someone who is taking their medication consistently and as prescribed can live a long, healthy life, just like someone who is HIV negative. And so we like to tag that with undetectable equals untransmittable, because when taking medication as prescribed, someone who is living with HIV can become undetectable, which means that with testing, their viral load is not traceable. And so the likelihood of them transmitting the virus to their partner sexually is actually eliminated. Any questions about undetectable equals untransmittable? Not everyone is typically familiar with that, and so I just like to hone in on that to ensure that individuals are aware that an HIV diagnosis is not what it once was. Okay. And then last but not least, when we're talking about HIV, it is preventable. Becoming HIV positive or even getting an STD positive diagnosis can be prevented. And there's several ways that prevention can happen. There's PrEP. Has anyone ever heard of PrEP before? PrEP stands for pre-exposure prophylaxis. PrEP is what we like to kind of call similar to a birth control pill, but it's for someone who is HIV negative who does not want to transition into becoming HIV positive. It's a one pill a day medication that someone who is HIV negative can take to prevent them from becoming HIV positive. So if someone is in a relationship with someone who is living with HIV, or perhaps someone is a sex worker or having survival sex in order to get food and housing, that's recommended. Or perhaps they're having multiple sex partners or having sex with anonymous partners who they don't know their HIV status. Getting on PrEP, the one pill a day medication, is recommended. And then there's also PEP. PEP stands for post-exposure prophylaxis. Typically, this happens with someone who has been sexually abused, perhaps like a rape victim, or it happens in clinical settings through occupational sticks, where someone may have been stuck accidentally. And so to ensure that they don't potentially develop HIV, then this medication is started, and it's typically a 28-day pill regimen that this person would take just to ensure that the HIV virus doesn't develop within their body. And then last but not least, the most common use that is used in terms of HIV prevention, in terms of methods, is condom use. There's the male condoms, the female condoms, and then there's also dental dams. And not sure if you guys have heard about that before, but typically that's used for oral sex as it relates to prevention. So any questions about HIV? Okay. So we talked about HIV, and at this point you may be asking yourself, okay, what does this have to do with me and my students? Why do I need to know about HIV, how it's transmitted, and what options are available as it relates to medication and or preventative methods? Let's talk about it. So what does the data say? Now, this slide is really wordy, so please bear with me. There's a lot of information on here, but it's a lot of useful information. So when we're talking about national data, what does the data say about HIV and STDs amongst young people? According to CDC, in 2018, 21% of new HIV infections in the U.S. were amongst youth aged 13 to 24. CDC also estimates that youth ages 15 and 24 account for almost half of the 26 million new sexually transmitted infections that occurred in the United States in 2018. So that's nationally. Well, Arkansas data is also similar to national numbers. So when we look at Arkansas specific data, according to the HIV surveillance report for the state of Arkansas, in 2018, 30.7% of new HIV cases were amongst youth aged 15 to 24. So primarily those are high school students. According to the STI surveillance report, 30.8% of chlamydia cases were amongst youth aged 15 to 19, whereas 21.6% of gonorrhea cases were amongst youth aged 15 to 19. So young people are being diagnosed with HIV and STDs. Oftentimes there's a misconception that if we don't talk about STDs or sex, that young people will not engage in it. Well, this in fact shows that that is not true. just because we're not talking about it doesn't mean that it's not happening. There is a direct correlation between HIV and STDs. Someone who either has or has had an STD is more at risk of an HIV exposure. And quite often, we actually see individuals co-infected with STDs and HIV. And so, again, the numbers are important because it further debunks the myth that just because we don't talk about it doesn't mean it's not happening. Young people are, in fact, sexually active. Yes, Suzanne.
So the question came in, when you're referring to STDs and HIV, is HIV not considered an STD?
Great question. So, yes, HIV is considered an STD. Um, Typically, the reason why HIV and STDs are distinguished is because sexual encounters are not the only way that HIV is transmitted. And so that's why typically you see HIV talked about separately, and then there's STDs. And when we're talking about STDs, we're talking about typically syphilis, chlamydia, and gonorrhea, herpes. Those are STDs that are transmitted sexually, as opposed to HIV. It's not only transmitted sexually, but yes, to answer your question, HIV is also a sexually transmitted disease. Yes, great question. Any other questions? I love it. So yes, definitely come with the questions. But again, just wanted to reemphasize that the data does show that young people are having sex. And so even though we're not talking about it, it doesn't mean that it's not happening. So over half of all U.S. teens have had sexual intercourse by the time they were 18. To be precise, according to CDC, it's actually 55% of U.S. teens have had sexual intercourse by the time they were 15. There are many factors that can either increase or decrease someone's potential HIV exposure, whether it's the type of exposure or the behavior that the person is engaging in. So, according to the 2019 National Youth Behavior Survey, these are actually the three most common activities that sexually active high school students engage in that increase their likelihood of HIV exposure. That's alcohol use, condom-less or unprotected sex, and then having multiple sex partners. So according to CDC, when we're talking about alcohol use, 21% of sexually active high school students either drank alcohol or used some sort of drugs before their most recent sexual encounter or their most recent sexual intercourse. As we know, alcohol use, substance use can impair our thinking and increases the likelihood of condom-less sex, thus putting the young person at risk of an HIV and or STD exposure. Furthermore, the data also shows when we're talking about sexually active high school students and sexual activity, 46% of them, according to this 2019 survey, 46% of sexually active high school students did not use protection or did not use a condom at their last or most recent sexual intercourse. So oftentimes, not only is alcohol coming into play where judgment is being impaired, but then also condoms or condom-less sex is happening. And then lastly, multiple sex partners. So 9%, according to the survey, 9% of sexually active high school students have 4 or more sexual partners. And so again, when we're talking about increasing exposure or likelihood of potential HIV exposure, having multiple sex partners and then multiple sex partners where condom-less sex is happening, and then when we're adding alcohol into the conversation, that increases the likelihood of potential HIV exposure. And so these are just risk factors or behaviors that our young people are engaging in. We know that they're being sexually active. We know that they're engaging in activities that put them at risk. But let's talk about prevention methods. So, is anything happening as well to try to prevent these methods or prevent HIV exposure? Absolutely. But there are some challenges that we run into. So when we're talking about HIV prevention challenges, these are just a list of some challenges that we run into as it relates to youth and HIV prevention. Those social and economic issues being one of them. Stigma, rejection, bullying, that is happening amongst young people. I'm sure you as educators are seeing this often. Typically, when a young person is rejected or being bullied, in the event they need assistance as it relates to HIV testing or condoms or seeking advice or a resource as it relates to HIV, that may not happen due to the stigma, bullying, and rejection that they face, thus preventing them from getting the care and services that they need. And then also, some young people are living in low income households, or they may have a parent who is incarcerated, or their household may not have health care or health insurance, thus preventing them from getting those prevention services, whether it be testing or condoms, or just getting the examination that they may need in the event they think they may have HIV and or an STD. And then also when we're talking about youth who may identify as lesbian, gay, bisexual, or transgender, students who identify with that particular group tend to have higher rates of stigma, rejection, and or bullying. They also have higher rates of physical abuse, emotional abuse, and or sexual abuse, whether it be inside or outside of the household. And so again, sometimes it's not just what's happening in school, as you guys know, it's also what's happening in the household as well. And then there's also inadequate sex education. So as you all know, sexual health education varies from state to state and sometimes from school to school. According to CDC, sexual health education has been insufficient. According to CDC, less than half of all high schools are actually teaching the sexual health education that's recommended. So young people aren't even getting the information, the education, or the knowledge that they need to ensure that they're making the correct decisions in the event they choose to either engage in sexual activity and or protect themselves. And then there's also high rates of other STDs. We talked about before how um, there's a direct correlation with STDs and HIV. Someone who has or has had an STD is at increased likelihood of an HIV exposure. Young people actually have higher rates of STDs compared to adults. Yes, Suzanne.
So the question was, I think this actually was from the previous slide. It just came in a minute late. Does
hmm
does the activity that you were referring to include oral sexual activity as well? I've seen the increase with youth and them not thinking that oral sex is having sex.
Great question. So typically, oral sex, when we're talking about um, unprotected or condomless sex in terms of what is considered most at risk and less likely in terms of HIV exposure, oral sex is actually low on the list in terms of sexual activity as it relates to HIV exposure. You are absolutely right. We hear that often as well, where a lot of young people think that, oh, because penetration didn't happen and it was just oral, that that's not sex, when in fact it is. But when we're talking about rates of HIV transmission, very rarely do we see HIV being transmitted orally through oral sex. The catch to that is it can happen, however, in the event there may be blood present in the person's mouth and then sexual activity is happening. For example, if someone has just gotten some dental work done, perhaps someone has gotten a wisdom piece tooth pulled out and there is an opening in their mouth and oral sex happens to take place and um, someone's ejaculation happens to be in that person's mouth, then yes, that is an open way for the fluid and the virus to pass into that person's body and thus possibly making them HIV positive. So that is the catch to that, but it does happen rarely. Oral sex is low on the list in terms of sexual activity as it relates to HIV transmission and exposure, but it's not impossible. It's just not as likely as other sexual acts.
Great clarification there. I wanted to point out, some of you have figured out that you can message me privately if you're wanting to ask a question and maybe it not be seen by the group. Feel free to do that on the chat where it says to everyone. Use that button and you can change it and send it just to panelists, and then only the presenters will be able to see it if you're more comfortable with that. And we do have another question, and I'm going to have to read it. Do you feel that the sexual content easily available to the youth by the entertainment industry and social media play roles in the increase of the youth having sex at a younger age?
Absolutely. Absolutely. The reality is, personally, is that everyone is influenced by what they see or hear. When we're talking about young people, sometimes and oftentimes they're more easily influenced as opposed to adults. Um, and when we're talking about social media, as this person mentioned, whether it's entertainment, so the internet being having easy access, click of a button to whatever it is that they see. Kids are exposed to a lot more nowadays in terms of body parts, sexual acts, even the language that is used. We tend to be in an over sexualized culture sometimes, not always, depending on what kids have access to. And so, again, when we're talking about influence, yes, as anyone, young people included, are influenced by what it is that they see. And so, yes, I do think that they are being influenced by what they see. We also hear it when we go to the schools and when we have conversations with youth about sexual activity. They talk about videos, attire, even pornography. When we're talking about certain, again, internet and what kids have access to, they are being influenced by what it is that they see. Great questions too, guys. Any other questions? Okay, so we talked about how HIV is transmitted. We talked about the data as it relates to um, the rates of STDs and HIV amongst young people. We talked about how there are high-risk activities that youth engage in that increase their HIV exposure, and then also those prevention challenges that we run into. There are a lot that plays against them, if you will, in terms of HIV exposure. But there are things that can be done, especially when we're talking about educators. Educators play a critical and vital role as it relates to HIV prevention. We know that the myth where if conversations aren't had or things aren't being said or done as it relates to HIV prevention or sexual activity, that, oh, they're not going to engage in sex. Well, we in fact know that that's not happening. So what can you as an educator do to assist with ending the HIV epidemic, especially as it relates to young people? And so I know the National Center for Education Statistics, they actually have, and you all may be familiar with this, they actually have a survey called the School and Staffing Survey. And according to that report, Arkansas, students spend on average 179 days per year in school, and that's an average of roughly 7 hours per day at school. You guys know this. You spend a lot of time with your students. And so typically most students are primarily in school quite often on a regular basis. So let's talk about what can you as an educator do to assist with ending the HIV epidemic or HIV prevention as it relates to young people. And there are some things that you can do. And so let's talk about it. So first and foremost is actually creating safe spaces, creating a safe and supportive environment that allows young people to thrive and be who they are, especially when we're talking about youth who identify as LGBTQ, lesbian, gay, bisexual, or transgender. As we talked about, youth who identify with that particular group have higher rates of sexual abuse, physical and emotional abuse, and then higher rates of stigma, rejection, and bullying. And so creating safe spaces for that particular group particularly, but then all youth to be able to just be who they are, talk to you as an educator in terms of a confidant, is important, and it's actually what CDC calls a protective factor. Studies have shown that youth who are more connected and engaged in school and engaged into activity and have relationships with adults at their school are actually less likely to engage in activities that put them more at risk for adverse health outcomes, i.e., potential HIV exposures. And so creating those safe spaces, especially whether it be in your classroom or just in a school setting, is very important, and it is considered a protective factor. And then also being knowledgeable about HIV and STDs. Educators are resources. Giving factual but appropriate information is important. The question was asked about the media and what kids are exposed to. We know internet is just a click of a button. Social media is just a click of a button. Almost all student has a smartphone, and so they have easy access to information, but that doesn't mean that it's all factual, i.e. why we also went over how is HIV transmitted? How is it not transmitted? What does that look like in terms of HIV? Being knowledgeable and sharing that information with your students is important, especially if students are coming to you as a confidant and they're engaging in sexual activity and they think they may in fact have been exposed to HIV or an STD and they have questions about that. Or if you as a educator, you're overhearing conversations where students are talking about sex and whether it be HIV or STDs, being able to clarify and provide factual information to these students is important. And so being knowledgeable about HIV, STDs plays an important role in HIV prevention. And then last but not least is also being knowledgeable about available resources. So knowing what students can have access to is just as important about being knowledgeable about the information. In the event one of your students are sexually active and they want to get tested or they need condoms, what are some resources? What do they have access to? You as a health educator, or I'm sorry, as an educator, can be a liaison between the student and the resource. There are several health units located throughout the state of Arkansas. There's actually one health unit in every county throughout the state. Young people, whether it's 13, 14, or 15, can actually go to the health unit and get services for free, and that is without parental consent. And so the health department will test and or treat students for HIV and or an STD if there is a need. And so students can go to the health department as a resource. Condoms are also available as a resource at the health unit as well. Students can walk to any health unit and ask for condoms and get those for free, and thus protecting themselves from HIV and or STDs. And then also, we do partner with multiple community-based organizations throughout the state. They too provide these services. And so in the event someone may be uncomfortable with going to the health unit due to a relative or a family member being there, there are also community-based organizations available. Yes, Suzanne.
They just asked that you repeat the ages that what ages are allowed to go to the health unit? Thank you. They're asking
Yes. So there is actually not an age. Anyone as young as 13, and well, let me clarify. If someone happens to be 12 or younger and they come to the health unit requesting sexual health services, typically we get child protective services involved due to them being so young. Sometimes there may be concern with sexual abuse present, but if a student or young person is 13 and older, they can come to the health unit and receive sexual health services, whether that be STD and HIV testing and or condoms and or birth control.
So the question was just popped back in, without parental consent or with parental consent?
Without parental consent. And we know that we typically tend to get a lot of pushback with that because understandably, parents are concerned with their child going to the health unit and receiving services, but the focus is treating the STD in the event a child is positive for an STD and they're engaging in sexual activities and or providing them with a preventative methods to protect themselves in the event they're having sexual intercourse.
And then just a clarification, someone had asked about the protective factor. And, as you were saying, studies show that if a student has one trusted adult, they have a much better statistical chance of coming through some of the challenges that they face as a youth. But just remember that when you're talking with youth and you're creating these safe spaces for them, if they disclose something that falls under that mandated reporter piece, then we can't make promises that we wouldn't tell or wouldn't share. We have to walk that line. So they ask how that fits in with mandated reporter, and mandated reporter always trumps any type of protective factor that we try to offer for our students. And we need to see it as getting them the help they need and getting them out of that situation is a protective factor. That's part of our role. So just clarifying that.
And thank you for saying that. And just to piggyback off of what you said, Suzanne, thank you for saying that. That is important because our policy is exactly the same. In the event any type of suspected abuse is going on or something that needs to be relayed to child protective services or whomever in terms of a parent or getting those services involved, ADH is mandated. We are a mandated reporter as well, so we too have to follow the same policy. So we also do that as well. So thank you for saying that.
And then I think this question is relating back to maybe the conversation about the age and children going to the health unit, maybe with parental consent, and correct me if I'm wrong, but is the testing confidential?
Yes. The
So
testing
even
is
for a parent,
confidential.
a parent wouldn't be notified if a 15-year-old was tested positive?
No, they would not. Now, to clarify, they would not be notified, but we would encourage the student to disclose their newly diagnosed status to their parent. So yes, they can come and get the services that they need, but having a conversation with a trusted adult, especially a parent, is communicated to students. But in the event they do not do that, we cannot force them. We do keep it confidential, but then they are still referred to services needed in the event there is a positive HIV diagnosis and or positive STD diagnosis as well.
And we do have several community health nurses and community health practitioners. I think I've got that acronym right. And so one of them just chimed in and said the child would need to ask for a confidential appointment.
Yes. And the reason that is at the health unit is typically it depends on, and I may be wrong, but from my understanding, it depends on whether or not insurance is involved. Because if a young person presents to the health unit with insurance and that card or information is displayed, it will be billed to their insurance. Now, typically, most minors are under their parents' insurance, and so, of course, that information will be received. So that is correct in terms of if somebody reports to the health unit wanting testing and has their insurance, but they want their visit to be confidential, they do need to make that clear. So great point. I'm glad that was brought up. I hope that clarifies or answers the question.
Just as you started saying it, she popped back in because of insurance. So yes, y'all were on the
Great.
same part. And then we do have another one, and I think this is probably back to maybe the mandated reporter type question. What are the what are the proposed steps that you would suggest if a student is verified as HIV and it is confirmed that the student is engaging in unprotected sexual acts with other students? And the acts, the acts were confirmed by all parties. Maybe it's not the mandated report. I read it wrong the first time.
Okay, so
Do I need to
just
repeat?
well, I can just to ensure, because I think I understood you, but just to make sure that I'm understanding the question is, maybe perhaps you're an educator and you know of a student who is living with HIV and he or she is engaging in sexual activity with other students. What is the next step as it relates to that? Is that the question? Yes?
Yes.
Okay. And so typically what we would suggest, because we've actually had that happen before, typically what we suggest would be to contact us and we would talk to the student. Now, what we cannot do is disclose the student's status to other students because that is a violation of HIPAA and confidentiality. We do have what's called disease intervention specialists, and what they do is contact tracing or partner investigations. So what we would do is the information that's provided from the educator in terms of who the student is, we will contact the student and let them know, hey, we were told that you may be engaging in unprotected sexual activity with, some of your partners. Who are they? And we would get that information and recommend that those students go in for testing. But maintaining that student's confidentiality and their status is important and will be done. But then also, once those partners are shared with us, we would contact them confidentially and recommend that they go and get tested for HIV. And we always include other STDs too.
And then the follow-up, are there any consequences to the student?
No. Nope, there's no, so the way that Arkansas is structured as it relates to HIV statuses and either disclosed or undisclosed information, typically that has to happen from the party who is the victim, for lack of a better word. So in the event a student happens to have sex with another student and does possibly transmit or give them HIV, that student would have to, if through their parents, if they wanted to, prosecute that student. That's not something that the person who either knew could do or us as a health department do. It's typically up to the person who is considered the victim, for lack of a better word, to do. So in the event, if they wanted to press charges or prosecute, they would have to do that in terms of consequences. But it's not something that we do or from my understanding, the school. Now, from my understanding, now, if the sexual activity took place on campus, now that's up to the school to enact any type of consequence. But in terms of the HIV aspect, that's specifically up to the victim.
So I think this question, I think you've answered it, but I just want to make sure. The question was, can a minor still be charged with a crime if knowingly having unprotected sex and not disclosing? And you're saying it would be up to the victim, the person they had unprotected sex with, to bring those charges?
Mm-hmm.
And they could bring charges? Okay.
They could bring charges, yes. They could bring charges, and yes, to reemphasize, yes, it would be up to the minor who is considered the victim to bring those charges, yes.
Okay. And then once a student tests positive, do they have to disclose their status to anyone?
No. So the only three people that anyone has to disclose their HIV status to is a current or future sex partner, their doctor, and or their dentist. So in terms of the school, a family member, a friend, All of that is optional and voluntary. Again, HIV is considered a chronic disease. And so if someone living with HIV is taking their medication as prescribed and they are undetectable, the likelihood of them transmitting HIV to their partner is eliminated. And so, thus, them not spreading the virus to someone else. But again, that's if they are taking medication as prescribed and undetectable. So, that is an important piece to know as we're talking about someone who is living with HIV, so they don't have to disclose their status. But if they do, it would have to be those three people: doctor, dentist, and future or current sex partner. And I hope that clarifies. Any other questions?
One just came in.
Yes.
Are charges only applicable after HIV is confirmed with the participant? So it could take years and would not be an immediate response?
So it doesn't take years for someone to show up positive on a test. The shortest time frame typically is 2 weeks. The longest is 90 days. So it just depends on the test and the timing. So there are some tests that can pick up an HIV exposure as quickly as 2 weeks. And then again, as I mentioned, to reemphasize 90 days, it just depends on where the person goes and gets tested and the type of test that's being done. Unfortunately, in terms of charges, transmission does not have to occur. The way Arkansas law is structured is whether or not disclosure happened. So even if both parties happen to be willing participants and transmission didn't occur, the student or even individual, charges can still be pressed against them, even if the partner who they were with did not get exposed to HIV. So again, even if condoms were used, even if the person who was living with HIV is virally suppressed and transmission did not happen, unfortunately, the person who is living with HIV does bear the burden of that encounter because they are the ones with the HIV positive status. And so charges still can be brought against him or her, even if transmission doesn't occur. So yes, charges can happen with or without transmission. And the reason why we say to the burden being placed on the person who is HIV positive is because due to modern medicine, as we talked about before, there are a lot of things in place that prevents HIV exposure and transmission. We talked about condoms, we talked about PrEP, we also talked about HIV treatment as prevention. And so we didn't get into about hate crimes and people who are living with HIV sometimes can face stigma and violence against them. And so, having to disclose your status to someone is necessary if you're engaging with them sexually, but then also sometimes it can also can also put a target on you, especially if you happen to disclose to someone. You don't transmit the virus to them sexually if that doesn't happen, and then that information is shared with others, and then you become a target. I hope that makes sense, clarifies. So, any other questions? A lot, especially when we're talking about young people and sexual activity. And so just want to reiterate too, we too are a resource when we're talking about what you can do as an educator. We talked about creating safe spaces. We talked about being knowledgeable and what resources are available. We too are a resource. If any situations occur and our services are needed, please don't hesitate to contact us. In the event you're an educator who would like to offer or does do sexual health education with your students, and you may be more comfortable with someone else delivering that information or message, don't hesitate to contact us. And then again, just want to reemphasize that you are a resource to and for your students, whether it's being a liaison for services, HIV testing and or condoms, and then also giving them the knowledge and information that they need as it relates to HIV. And so I love the questions that you guys are asking because based on what we see, typically students have the same questions. And if they can ask you, that's awesome.
So I just want to point out, we are coming up on the 2 o'clock hour, but I think this
Okay.
is amazing information. And I don't know how many more slides you've got on, but I will say to our participants, if you're free to hang out with us, if Z is okay to keep going, we'll record, we'll keep going, and then you can always pick up with the recording if you need to. I know time is tight. It's summertime. You may have some ice cream you need to go eat with your kiddos, and that would be fabulous. So feel free to jump off if you need to, and you can look for the recording when we're done. I am going to post in again all those links I mentioned in the beginning of how to reach me to let me know if you need a certificate, if there's extra people in your room, how to get on our mailing list, where to find the recording. I'll post all that back in, but Z, go ahead and keep going. I think you've got an eager audience still.
Well, thank you so much, Suzanne. And that's actually perfect timing because that was, in fact, my last slide. The only other slide after that was questions. And then I also wanted to share our contact information. So again, I am the HIV Prevention Program Manager for the HIV Prevention Program here at the Arkansas Department of Health. But I also wanted to include Darian Adams' information because she is our new public health educator. We are so excited to have her. And so if anyone would like her to come out and do HIV and or STD education, that sexual health education piece that we talked about, don't hesitate to contact her. We are a resource as well, and we would love to partner with you to provide your students the services and information that they need.
We do have a couple other questions. The most pressing, I'm sure everyone wants to know is, will you share your PowerPoint?
I sure can.
What I'll do is I'll gather that from Z and I will post it on the website along with the recording. And once we have the recording posted and I've got all the certificates done, I send out back an email to everyone who is registered. So whether you attended or not, you'll get a message saying, hey, here's the resources, they're up and available. So you can watch for that to know when it's posted. And the question that came in, and I think I'm repeating this right. So if the person's still on, I've got it wrong, chime in and let me know. But it's going back to the PEP, PEP. And I think you mentioned that anyone who, or children who suffer sexual abuse or administer that. So they're asking, is it done automatically if a child is being treated for sexual abuse, or does it have to be requested?
So I'm going to say it has to be requested because, of course, it's prescribed in a medical or clinical setting, typically at a hospital. So that means, and let me add to that too, it has to be taken within 72 hours after the potential exposure has happened. So unfortunately, if the child waits to disclose what has happened, and it's outside of the 72-hour window, PEP will not be prescribed. What potentially will happen is them being tested within a given time frame to ensure that an HIV exposure didn't happen. But as it relates to PEP, in order for it to be prescribed, it has to, the 28-day regimen has to start within 72 hours after exposure. And typically it is prescribed in the clinical setting once that information has been shared. But again, that 72-hour window is key.
So I think they're just asking for clarification, 72 hours since the latest encounter. So like, I guess if it had been ongoing for months or something, 72 hours since the last encounter.
So 72 hours since the latest condomless exposure. Now, and it's tricky because in the event someone has been engaging condomless with the same person for an ongoing basis, and the person happens to be living with HIV, then PEP is not a recommendation because technically, usually it's given to someone where there's a one-time exposure, not necessarily where there's an ongoing sexual encounter that's happening condomless. So typically it's done after a one-time exposure. Now, if someone is engaging in sexual activity and they don't know the person's HIV status, PrEP, PrEP would be recommended versus PEP because PrEP is the one pill a day regimen that someone can take to ensure that they don't transition to a potential HIV positive diagnosis if they're having ongoing condomless sex with someone whose HIV status they do or don't know. I hope that clarifies.
I think they came back in and said those children who have been suffering abuse. So I think they're thinking about possibly molestation or human trafficking or
Gotcha.
something along those lines. So okay.
Gotcha. Yes, and so we do know that sometimes abuse is not a one-time deal. Unfortunately, some kids are being abused regularly, and unfortunately, that still applies. So if it has something that was a more than one-time basis and it was condomless, typically PEP would not apply for that situation. Any other questions? I love the questions. Definitely feel free to ask. That's what we're here for.
I think it's been a wonderful presentation, and then I do think the questions have added so much to it. So I appreciate everyone who's been chiming in. I have made Darian and Crystal and Sharia and Lisa. Y'all are all co-hosts now. You're able to unmute if y'all would like to, have questions or engage. Y'all are kind of the lead subject matter experts in this area. So I just wanted you all to have an open mic opportunity. Just accolades are coming in through the chat for you. Great job as people are having to drop off. They've really enjoyed it.
Thank you. Thank you. Thank you.
I said to a few people, I'm a child of the 80s. I came up under the message of AIDS and HIV was a death sentence. I mean, there was a much different messaging piece back then. And as time wore on, I either didn't keep up or didn't learn or didn't know kind of some of the new differences, the nuances. So this has been really educational for me and eye-opening. It's helped fill in a lot of knowledge gaps that I had that I didn't even know I have.
Yeah, and thank you for saying that too, Suzanne, because you're absolutely right. What HIV was when it first hit the scene compared to what it is now has completely changed. There's so many more resources available, and someone with an HIV positive diagnosis can live a long, healthy life as someone who is HIV negative. And so that's why, even though we share information about HIV transmission and preventative methods, we also want people to know that in the event you encounter someone who is living with HIV, or you happen to have a friend or a relative who has been newly diagnosed with HIV, to encourage them because it's life beyond HIV. The medications are effective. There are so many resources available, and so we don't want to further add the stigma, rejection, and discrimination that exists for people living with HIV. And so that's why having these conversations are so important, because there's so much available out there. So thank you for saying that.
And I can also see, my generation is we're of the age that we've got those kids in high school now and are kind of coming of that sexuality age. And so, if there are parents who are still living with a misunderstanding, then that's just perpetuating it. So I can just see how getting new, and I think educators are always the ones saying we need the newest and latest information. We want to be on top of everything, and this has certainly helped do that today. So I'm not seeing any other questions in the chat, but feel free to pop them in there as we kind of hang out. One more time, I'm going to pop in all those links that I've talked about. I think I've sent them about 10 times to individual people. If y'all send me a message, it defaults my response back to y'all, so my apologies. But I think I finally got them out to everyone. And again, this is being recorded. We'll put it up on the website. We'll also collect Z's PowerPoint and put it up as well. And I think the questions have all been answered through the chat, but I'll go back through, and if I've missed any, I'll feed them to Z, and we'll get those answers and put them up as a Q&A or something. We'll make sure it's all addressed.
I do have one last question, Z. Do y'all still have the ability, or I was thinking that students could scan something like a QR code to learn about HIV themselves, or didn't we have that at one time at the health department?
That would be awesome. Unfortunately, we don't have that.
Okay, maybe I'm
but
thinking something else then.
I mean, that would be so awesome. CDC.gov is a trusted source for information about HIV and STDs, and then also visiting the ADH website. Our website is a little longer, healthy.arkansas.gov. So if that's too long to remember, then of course, CDC.gov is a trusted site, because we do on ADH website share a lot of links from the CDC website. So I would also suggest if students have questions and want more information, they can just type that in their phone, go to their app and just, type in cdc.gov and just scroll and get what they need.
Okay, I just was thinking about something easy for them, like maybe the health department might create in the future.
Great idea.
For schools
definitely something to look into.
Put up in the bathroom or wherever.
I love that idea. I do, definitely. Yep.
Okay. There used to be an HIV test center at our building on West 3rd. Did it move? Let me read that again. There used to be an HIV test center at our building, 2020 West 3rd, Little Rock. Did it move?
What's the name of the building? The address isn't ringing a bell. What's the name of the building when you say our building? Is that a school?
I think she's a state employee. Oh, executive building.
Oh, you know what? It sounds like you may be referring to the R-Care location that used to be, are you talking about Financial Center Parkway? Because I know they do have a new location. If that's the area I'm thinking about, I don't know their address offhand, but if that's where you're talking about, if I'm not mistaken, they have recently moved.
I think she's, if I've got it right, it's the one over here behind the Capitol on West 3rd, just down from the Capitol on 3rd Street. And then someone else says that was Jefferson Comp office.
Jefferson, yes, they do still offer HIV testing. Yes. Okay, yes. Okay. Yes. And they're actually one of our partners. So they also have community outreach. So you can either go there or they can come to you. So if someone were hosting a testing event or needed someone to come out for HIV testing or education, they too can provide those services. I love it.
Thank you all for sticking with us. I know this the week after a holiday, my brain is fried. I can't even think of
Need some ice cream.
This week. Yeah, I need some ice cream. So thank you for joining us. We appreciate it. And watch for this presentation to be posted. Please share it with your colleagues. We want to get this information out. When you fill out the survey or the response, give us feedback for Z. I know she would like that as well. But if there's other topics or information that either her office or my office could facilitate for you, that's what this is all about, is increasing our knowledge for everyone. So Sharia and Lisa, do y'all have any last closing words?
Thank you.
Yeah, I think it was Lisa's teachers and Sharia's nurses that were our main audience today. So thank y'all guys for that. And we'll close off and see you next time.
Bye. And of course, Suzanne, feel free to share my contact information and Darian's contact. Thank you for having us and allowing us to come and share this information. And so, of course, as you mentioned, if you guys need anything, don't hesitate to contact us. We would love to partner with you guys and be a resource if you need us for anything. So,
absolutely. Thanks, everyone.
All right. Bye.